Hello everyone, this is Dr. Rusek. I am an Associate Program Director for Ocala Internal Medicine Residency Program. I am also an infectious disease board-certified physician. In today's lecture, we will talk about antibiotics. Of note, we only have time enough to talk about antibiotics in terms of antibacterials, and antifungal as well as antiviral medications we will have to devote to another time. In introduction part of this lecture, we will talk about subdefinitions as well as history of antibiotics. So what is an antibiotic? An antibiotic is a substance, usually derived from a bacterial source, that controls or kills other bacteria. Later on, synthetic antibiotics were developed and perfected to address the same exact tasks. You can separate antibiotics into certain groups based on their spectrum, route of administration, or type of activity. Antibiotics are classified also based on a structural group. This way they have the same mechanism of action as well as level of effectiveness, toxicity, or side effects. When we talk about broad-spectrum antibiotics, we talk about antibiotics being effective against a broad range of microorganisms in comparison to narrow-spectrum antibiotics, which are effective against few bacteria. What you can easily deduce from the name, bactericidal antibiotics kill bacteria, where bacteriostatic antibiotics usually only halt the growth of bacteria. Majority of you have heard about different cultures in the past using certain mediums to treat infections. We have heard about molds or plants with medicinal values, moldy bread or warm soil, sometimes also sour milk or beer was used to treat infections. If you look at more modern history, starting in 1600s in England, there was a strong interest in molds that were actually being recommended in pharmacology books at the time to treat infections. In 1800s, these recommendations were actually supported by some studies that revealed that mold did prevent bacteria from growing. There was a special interest in the penicillium fungus, which was said to have antibacterial action on human tissue. This was further explained in 1875. In 1877, Louis Pasteur postulated that bacteria could kill other bacteria. There were reports of animal studies in which typhoid was cured by use of mold with penicillium. Finally, in 1900s, we have an era of Sir Alexander Fleming. In 1940s, 50s, streptomycin, chloramphenicol, and tetracycline were first discovered and used and named antibiotics. This term was first used in 1942. As you see, discovery of antibiotics is fairly recent. We waited up until 1928 to have the first antibiotic created by Alexander Fleming. Because of this discovery, Sir Alexander Fleming is considered the father of antibiotics. Thanks to him, we have a cure for syphilis, and initially we also were able to use penicillin in cases of gangrene, tuberculosis, as well as pneumonia. He has also famously said one sometimes finds what one is not looking for in terms of his ability to isolate penicillin from the mold penicillium. What one has to pay attention to in regards to antibiotics is that immediately after development of an antibiotic class, we quickly followed with development of bacterial resistance, which on this time chart is shown in such a profound way. Initially, this resistance was overcome by creating new antibiotic classes, a new category of antibiotics. But by the time we reached 1980s, we were stuck using the antibiotics we already had, trying to widen their spectrum and their applicability. We started seeing the first ESBL resistance, or vancomycin-resistant enterococcus, known as VRE. Over time, these just became more prominent, and now they are more talked about. Now that we are done with the introduction, let's get to the main part of this lecture, the talk about antibacterials. It's quite impressive to see how over time we've developed antibiotics that affect very many places in bacterial structure. There's a large group of antibiotics that affect cell wall synthesis. There are several antibiotics that affect protein synthesis. Also, several enzymes that are inhibited by antibiotics like DNA gyrase or RNA polymerase. Several antibiotics affect cytoplasmic membrane structure, or folic acid synthesis. You should know that beta-lactams as well as vancomycin affect cell wall synthesis. You should also know that quinolones affect DNA gyrase. You should remember that protein synthesis is suppressed by macrolides, tetracyclines, as well as aminoglycosides. And also remember that Bactrim affects folic acid metabolism. As we already mentioned, there are two types of antibiotics. In the bacteriostatic group, we do have several antibiotics that we use very often, like doxycycline, azithromycin, linezolid, as well as the antibiotic that's not so widely used, tigecycline. We also need to briefly mention vancomycin because although it appears bactericidal toward Staphylococcus group of bacteria, it is definitely static against Enterococcus, and some of these interactions are concentration driven. Some other bactericidal antibiotics that we have listed here we use very often: beta-lactams, quinolones, sometimes also rifampin or metronidazole. And as we see, even though sulfonamides or trimethoprim are in the bacteriostatic group, we do know that Bactrim, therefore the combination of sulfamethoxazole as well as trimethoprim, does achieve bactericidal effect. Before we move on, we have to introduce two concepts: minimum inhibitory concentration, or MIC, and minimum bactericidal concentration, or MBC. MIC stands for the lowest concentration of antibiotic that prevents active bacterial growth. And you know this number because you do get MIC breakpoints in every single culture result. MBC stands for the lowest concentration of antibiotic that blocks all growth of bacteria, and this is a permanent effect. This drawing represents these two concepts very well. You start out with a control test tube that is full of bacterial colonies, and you proceed to add antibiotic at increasing concentrations. With increasing concentrations, you do see that growth of bacterial colonies decreases. Once you observe absence of bacterial colonies, you can call that concentration minimal inhibitory concentration. You continue adding antibiotic to the top row of test tubes because you are interested in minimum bactericidal concentration as well. As you see, small amount of each of the test tubes at MIC level and above are transferred to fresh medium that contains no antibiotic, and you see that the test tube at MIC level, now transferred to a medium without antibiotic, will start growing bacterial colonies. However, at the level of minimum bactericidal concentration from above, that concentration was lethal to the bacterial colonies, and even if transferred to a fresh medium, that broth won't grow bacteria any longer. That's your minimum bactericidal concentration. There is one more very important concept in antibiotic administration. You've probably heard about concentration-dependent killing or time-dependent killing, where you have two completely different principles guiding the dosing of antibiotics. Some need to achieve a high concentration to be able to do its job. Some do need to remain above the MIC level for majority of the time to be able to do their job. As I said, this is all taken into consideration where pharmacists do studies on these antibiotics and decide what dosing is the most appropriate. This later translates into clinical cure, and if the concept is not fully supported by clinical practice, then further studies are done to discern why that is. First large group of antibiotics we will talk about are beta-lactam antibiotics. The name comes from the chemical structure which does possess beta-lactam ring. There are two side rings that are different amongst the members of this group. All beta-lactam antibiotics bind penicillin binding proteins. They in turn inhibit the cross-linking between peptidoglycans, and in this way they cause bacterial lysis. Aztreonam is a monobactam, which means it only has one ring, beta-lactam ring, and it does not contain any side rings. This is very important when you're trying to treat penicillin allergic patients and you're using aztreonam. In beta-lactam category of antibiotics, we have penicillins, cephalosporins, monobactams, and carbapenems. We will talk about penicillins first. Natural penicillins were the very first penicillins that were available for treatment of patients with infections. Upon isolation of penicillin from penicillium mold, we started production of natural penicillins. Natural penicillins have a very short half-life. They are excreted renally and tend to penetrate every inflamed body cavity. We still use natural penicillins for treatment of strep throat, syphilis, leptospira infections. Next up are aminopenicillins. Aminopenicillins have better oral absorption. They're also excreted renally, have somewhat of a broader coverage, and that's why they were developed. They are known to treat Listeria, Enterococcus, also Proteus, and have pretty good anaerobic coverage. Next up, we have penicillinase-resistant penicillins. Those are cleared hepatically, and in this group we have most commonly the examples of nafcillin and oxacillin. Those are specifically used for methicillin-sensitive Staphylococcus aureus. They do not have much of any anaerobic activity. Carboxypenicillins or radopenicillins. Those are very much advanced penicillins that have been developed over time to specifically fight pseudomonal infections. Those are typically used in very severe infections of abdominal or urinary etiology. They do cover methicillin-sensitive Staphylococcus aureus as well, and Enterococcus species that are ampicillin-sensitive, and can be used against ESBL strains if confirmed to be sensitive in vitro. So let's look at common examples of all of these categories. Starting with natural penicillins, this is where we see penicillin G. This is the penicillin that we use against syphilis. Next, we have aminopenicillins. This is the group with amoxicillin, ampicillin, as well as ampicillin sulbactam or unicin, and amoxicillin clavulanate or augmentin. We already mentioned the two most common penicillinase-resistant penicillins, oxacillin and nafcillin. We do not use ticarcillin in the United States, but we do use piperacillin, which in combination with tazobactam gives you zosyn, which is very commonly used. Zosyn is a uridopenicillin. Let's talk about another group of beta-lactams, cephalosporins. Cephalosporins are organized into generations. First-generation cephalosporins have mainly gram-positive coverage, do not penetrate cerebrospinal fluid space, but can cover community-acquired gram-negative rods, as is common in urinary tract infections. Second-generation cephalosporins have a bit more gram-negative coverage, less gram-positive coverage. Third-generation cephalosporins have broad coverage for both gram-negatives as well as gram-positives. They notably cover methicillin-sensitive Staphylococcus aureus as well as strep species. They are also very good at covering majority of gram-negative organisms with the exception of Pseudomonas. Ceftriaxone belongs to the third-generation cephalosporins and has hepatic metabolism. Ceftazidime is another third-generation cephalosporin, but it's a tad different. It was developed for its anti-pseudomonal activity, but it does have no gram-positive coverage, so again, it's an exception. Fourth-generation cephalosporins are very good at gram-positive as well as gram-negative bacteria. That's your cefepime, and can be used against ESBL strains as long as proven to be sensitive in vitro studies. Fifth-generation cephalosporin is ceftaroline. Ceftaroline is used for MRSA or vancomycin intermediate or daptomycin-resistant strains of Staphylococcus aureus, as well as penicillin-resistant strep pneumoniae and vancomycin-resistant strep pneumoniae. You've definitely seen a chart that looks very similar describing the spectrum of coverage in different generations of cephalosporins. Again, this does hold true for the most part, but there are definite exceptions. I would like to solidify one important fact, and that is that cephalosporins in first and second generation do not penetrate the central nervous system, as opposed to third generation, fourth generation, and fifth generation. Those generations have capability of penetration of central nervous system. They can be used in management of central nervous system infections, such as ventriculitis or meningitis, or even brain abscess. Just to solidify our knowledge in terms of cephalosporins, we will go through these different cephalosporins that belong to different categories. So we have first generation cephalosporins that notably include Keflex or cephalexin, as well as cefazolin or Kefzol. Keflex is an oral formulation, cefazolin is of course an IV antibiotic. Most commonly used second generation cephalosporins are cefpodoxime or Ventin, cefuroxime, Ceftin. Everybody knows that ceftriaxone belongs to the third generation cephalosporins. Cefdinir, which is oral form of ceftriaxone, is Omnicef. But let's not forget about ceftazidime or Ceftaz, which is another IV third generation cephalosporin. But remember, it does not contain any gram-positive coverage. If you're going for a broad-spectrum antibiotic, ceftazidime needs to be given with vancomycin or other antibiotic that's mainly gram-positive in coverage. We had a shortage of cefepime 2-3 years ago. Ceftazidime was used in combination with vancomycin for coverage of sepsis. Cefepime, as we already mentioned, is a fourth generation cephalosporin, and ceftaroline is a fifth generation cephalosporin. Ceftaroline is considered 3.5 generation cephalosporin by some because it does not contain coverage for Pseudomonas, but it does notably cover MRSA. Alright, so let's move on and cover monobactams. There's only one monobactam we currently use and have at our disposal, and that is Aztreonam. You've heard already about this antibiotic when we were discussing structure of beta-lactams. Because of its monocyclic structure, Aztreonam has been used in penicillin as well as cephalosporin allergic patients with great results. It appears that the side chains and the side groups are most commonly implicated in allergic reactions. Therefore, monobactam being significantly different from penicillins and cephalosporins can be safely used in these patients. Aztreonam is very similar to ceftazidime when it comes to its spectrum of activity. It works only against gram-negative bacteria. So for coverage of gram-positives or empiric coverage, you need vancomycin or other gram-positive agent. Aztreonam does have anti-pseudomonal activity. It does cross into central nervous system. It does not cover Enterococcus, but what you have to really remember is that cephalosporins do not cover Enterococcus either. It is renally metabolized. We are ready to move on and discuss carbapenems. Carbapenems as a group is known for its ESBL activity. Extended spectrum beta-lactamase resistant organisms are covered by carbapenems. Of note, these antibiotics are usually more expensive. We will also have only 1 or 2 available at our disposal, only restricted towards specific use. So ertapenem is carbapenem that does not have any pseudomonal activity. The half-time of ertapenem is long, and therefore it only needs to be dosed once a day. This is an excellent antibiotic for outpatient infusions if you have an ESBL organism that is not Pseudomonas species. Meropenem is the carbapenem of choice in a lot of institutions. It does cover Pseudomonas. It is a very broad antibiotic. It has anaerobic activity and it's used in very complicated abdominal infections. Imipenem is one of the antibiotics that we usually have to order. We use this antibiotic specifically for severe nocardial infections, say nocardial brain abscess, or in treatment of Mycobacterium avium. Of note, higher generation penicillins, as an example, Zosyn, Piptazo, can cover ESBL organisms. So can cefepime, as long as they are confirmed to be effective in terms of their MIC's breakpoints. And those will vary with every single ESBL organism. That breakpoint will be different. Since 2015, we have seen new beta-lactams developed. Ceftazidime avibactam, or Avicaz, was introduced for treatment of MDROs, multiple drug-resistant organisms. Then in 2016, we had ceftolozone tazobactam or Zerbaxa introduced on the market. And then finally in 2017, we had meropenem vaborbactam introduced as Vabomere. Avicaz and Zerbaxa have to be used with flagyl or metronidazole to obtain anaerobic activity. Vabomere already has built-in anaerobic activity of meropenem. All of these antibiotics do cover Pseudomonas. They are indicated for carbapenem-resistant organisms, for UTIs, pneumonias, intra-abdominal infections. They are all renally cleared. Every single one is supposed to be given on every 8-hour basis. All drugs, including antibiotics, are going to have some toxicities that are more or less common. For beta-lactams specifically, allergic skin rash or anaphylaxis seems to be the most common and most talked about. Some antibiotics, including imipenem, have tendency to decrease the seizure threshold. Cefepime, for example, in a situation of renal failure, accumulates and causes encephalopathy. Diarrhea is very common with beta-lactams, as pretty much with any antibiotic. Ceftriaxone has a potential of causing cholelithiasis. Penicillins, cephalosporins, aztreonam all can cause cytopenias, although rarely. Liver functions have been observed to rise in the setting of ceftriaxone especially. We are now going to talk about aminoglycosides. This group of antibiotics has fallen out of favor because of antibiotics that were created semi-recently with better coverage and less toxicity. For example, when we deal with resistant organisms, and now we will reach towards Avicaz, Zerbaxa instead of aminoglycosides. We still use aminoglycosides in synergistic treatment of streptococcal, enterococcal, and pseudomonal infections. Endocarditis guidelines do ask for synergistic dose of gentamicin in certain endocarditis. Addition of gentamicin in treatment of highly penicillin susceptible viridans group strep can shorten the therapy to 4 weeks. Gentamicin synergistic dose is also recommended for prosthetic valve endocarditis when it comes to streptococcus. Gentamicin synergistic dose is also added to prosthetic valve therapy against staphylococci, whether MSSA or MRSA. Similar applies, although for both native and prosthetic valve endocarditis in terms of enterococcus. As opposed to beta-lactam antibiotics, which exhibit time-dependent killing, aminoglycosides exhibit concentration-dependent killing. And because of that high dosing that is required to achieve the concentration needed to kill bacteria, the nephrotoxicity and autotoxicity are so common and so devastating. Aminoglycosides block protein synthesis within the bacteria. They block initiation of protein synthesis as well as translation, eliciting premature termination of protein synthesis, sometimes also incorporating incorrect amino acids. Here we have a table with aminoglycosides. In the United States, we have seen use of amikacin, gentamicin, streptomycin, as well as tobramycin. Streptomycin is not readily available. Neomycin and sometimes tobramycin are used in ophthalmic formulations or topical formulations. An experienced pharmacologist is usually able to help with the dosing, as it is very complicated and a lot is at stake if a mistake is made. Things have changed dramatically, and as I've said before, we rarely use aminoglycosides now for gram-negative infections. Rather, we use it in endocarditis and for other indications. We have used amikacin, for example, in mycobacterial infections. We also have used streptomycin or gentamicin in cases of Yersinia pestis or tularemia. Alright, we are now going to start discussing glycopeptides. All of you know a glycopeptide, which is vancomycin. It's a first-generation glycopeptide, although you might not know that it belongs to glycopeptides. There's also a second-generation lipoglycopeptides, telavencin, dalbavencin, ordavencin. Those are all the long-acting glycopeptides that have been recently introduced for one-time treatment of simple skin and soft tissue infections. All glycopeptides are bactericidal. It is a concentration-dependent killing. At the right concentration within the organ, all of those antibiotics are bactericidal. Glycopeptides block cell wall biosynthesis. They block transpeptidase and transglycosylase. To do that, vancomycin has to bind to D-ALA sequence of the cell wall. Because of the lipophilic side chain that has been added to the second generation glycopeptides, these antibiotics have second site where the binding with cell wall can occur. Therefore, they are thought to be better in terms of binding VRE as well as Visa and Versa strains, vancomycin intermediate and vancomycin resistant strains of Staphylococcus aureus. This is especially true for oritavancin, which has activity against vancomycin-resistant Staph aureus as well as all vancomycin-resistant enterococcal strains, both the Ven A and Ven B carrying VRE strains, as opposed to dalbavancin, which has poor activity against vancomycin-resistant Staph aureus and only Ven A strain activity. Oritavancin is a longer infusion. It's infused only once. The dose is slightly smaller. It does interact with some drugs, including warfarin, but it does not need any renal adjustment as opposed to dalbavancin, which does need renal adjustment for creatinine clearance of less than 30. Dalbavancin also needs to be used with caution in hepatic dysfunction. Because of its similar structure, both dalbavancin and vancomycin receiving patients are at risk for Redman syndrome. Redman syndrome is a classic appearance of flashing of face, neck, upper thorax, which is due to histamine release because of the hyperosmolarity, but it is not a true allergy. It's resolved with slowing down of the infusion to over 1 hour. Of course, this has to be explained to the patients as they usually recall this as true allergy, which it is not. As you've likely noticed, the moment we stopped talking about beta-lactams, aminoglycosides, and started talking about glycopeptides, vancomycin, we entered into antibiotics that were specifically developed to fight resistant gram-positive infections. Up to that point, penicillins, broad-spectrum penicillins, were really good about addressing streptococcal, staphylococcal infections. But with the methicillin resistance, which came in 1960s, vancomycin was developed as the antibiotic to fight those infections. And so we will have a couple of antibiotics that we will discuss that are specifically coverage of gram-positive bacteria. We're about to discuss daptomycin. Daptomycin is a lipopeptide. It is a cidal antibiotic. It does exhibit concentration-dependent killing. Its proposed mechanism is shown here on the slide. It binds the cytoplasmic membrane and forms complexes in a calcium-dependent manner. This allows arrest in DNA, RNA, protein synthesis, and therefore bacterial cell death. Because of calcium-dependent binding, daptomycin can affect calcium channels that are present on muscles, and therefore daptomycin, as one of its side effects, it can cause muscle pain with CK elevation and weakness, which is what we have to watch out for when we have patients on daptomycin. We have to check the CK level before initiation of infusion and then weekly while the patient remains on this medication. Beyond muscle pain and weakness that daptomycin can induce, it can also lead to peripheral or even cranial neuropathy, and this is a known side effect that we have to be conscientious of. Daptomycin is a very good antibiotic for coverage of MRSA, VRE strains, resistant strep strains, as well as coag-negative staph if indeed there is an infection. We tend to use daptomycin in infections where vancomycin is contraindicated, whether it's because of the renal function of the patient or possibly the staphylococcal strain has an uptrend in the MIC over time, and we cannot control the infection with vancomycin alone. Two final remarks when it comes to daptomycin. It does not penetrate central nervous system unless there's meningitis or inflammation of the meninges. And it also does not penetrate long parenchyma. So if a patient has an MRSA pneumonia, for example, we cannot use it in that setting. We have successfully used it in a setting of, let's say, vascular complications, when you have a patient with MRSA endocarditis and the patient has septic emboli to the lung. All right, so now that we talked about vancomycin, daptomycin, we are going to talk about linezolid, the third antibiotic that's used for gram-positive bacteria only. Linezolid is an oxalidenone. It binds 50S ribosome, the same site that chloramphenicol binds, and it blocks initiation of protein synthesis. It is a bacteriostatic antibiotic, and it causes several bone marrow side effects, including thrombocytopenia, also leukopenia, we've seen that, and transaminitis. Those are usually reversible in terms of stopping linezolid and improvement in the blood count. What you really have to be careful of is that linezolid, especially when used with SSRIs, can cause serotonin syndrome in patients. So basically, as long as the patient, the candidate for linezolid, is on SSRIs, linezolid cannot be used. It's contraindicated. Linezolid has been initially developed as an antidepressant. However, its long-term side effects have prevented people from being able to use it in such a way. Its antimicrobial activity, however, can be used for short term, usually up to 2 weeks of therapy, and that's what we've been doing. So just as with daptomycin, linezolid is used against MRSA strains, vancomycin intermediate and vancomycin resistant strains of Staphylococcus aureus, as well as strains of vancomycin resistant Enterococcus. Now, if vancomycin is contraindicated, linezolid is definitely an option. What you really are benefiting from when using linezolid is that its IV and oral availability is exactly the same. So you can switch an IV linezolid to oral formulation and you won't be losing any coverage. Another comment about linezolid is that it actually penetrates blood-brain barrier, and so it can be used effectively in central nervous system infections, including brain abscesses. We will briefly mention remaining antibiotics. The ones that you are interacting with a lot are macrolides, specifically azithromycin. Sometimes you see clarithromycin used, fidaxomicin a little less. We haven't been hearing that much about resistant Clostridium difficile lately. Azithromycin is a long-acting macrolide. It persists at therapeutic levels in the serum for 5 days, and it's used mainly against atypical bacteria like Legionella, Mycoplasma, Chlamydia, Haemophilus, Uroplasma. These are bacteria that you will not be able to isolate from a culture. That's why they're atypical. What you have to worry about with these antibiotics is prolonged QT interval, some hearing loss. It can actually exacerbate myasthenia gravis. It will interact with other drugs. Another group of antibiotic, tetracyclines. Here you have short-acting and long-acting tetracyclines. We pretty much use doxycycline, sometimes minocycline out of that group. Doxycycline has a broad spectrum of activity against atypical microbes, like what we mentioned for azithromycin, but it also has activity against Lyme, Brucella, and Rickettsia. So we definitely use doxycycline a lot in unusual infections. It has a pretty good coverage for Staphylococcus aureus and MRSA, so we have been using it in skin and soft tissue infections as well. You need to advise the patient on photosensitivity, especially here in Florida. We need to warn the patient not to sit out in the sun as it can promote sunburns. It is not recommended in pregnancy or for children less than 8 years old. Another long-acting tetracycline is tigecycline, Tigecyl. When it was first introduced, people were very hopeful about its broad spectrum coverage for gram-negative bacteria. It was used broadly in intra-abdominal infections. It wasn't really good about staying in the bloodstream, but it was very good at penetrating tissues, especially helpful with intra-abdominal infections, abscesses, and so forth. But unfortunately, in 2013, FDA issued a warning about increased risk of death when intravenous Tigucil is used. These patients did worse on Tigucil than other IV antibiotics that are available to us, indeterminate of any other factors. So long story short, we really don't use Tigucil any longer. Moving on to clindamycin. Clindamycin has been used a lot by older physicians for treatment of anaerobic infections of mouth. In general, it was accepted that clindamycin was, for whatever reason, superior in treatment of infections above diaphragm. This is not true. Clindamycin, for me at least, is useful only when it comes to blocking toxin productions in fulminant infections of skin and soft tissue, like necrotizing fasciitis. I use a high dose for about 48 to 72 hours, and that's it. It independently increases risk of Clostridium difficile more than any other antibiotic. It persists in the stool, it alters microbiome of the whole entire body, so I would be very cautious in using it. I will not leave you without an alternative. Metronidazole is a very good anaerobic antibiotic. It's not without any harm. It still has to be weighed against risk and benefit. Metronidazole can be used for infections above, below diaphragm. It does have a very peculiar disulfiram-like reaction with alcohol consumption. So if you have a patient that is an alcoholic, you have to advise them, if you drink alcohol with this medication, you will be very uncomfortable. If a patient is on warfarin, you have to pay attention to INR, which is an applicable statement to any antibiotics. You have to watch INR. Metronidazole has been used in Clostridium difficile infections. It has been used in Helicobacter pylori infection, trichomonas, amoeba, giardia. It's a very good antibiotic for a lot of things. We're moving on to quinolones. All quinolone antibiotics that are available to us in modern use are fluoroquinolones, which basically means they contain fluorine atom in their chemical structure. Here we have a list of all of the quinolones that have ever been put on a market. We know the second generation ciprofloxacin, third generation levofloxacin, and fourth generation moxifloxacin. Those are the ones that are the most common. With each generation, the spectrum of activity is a little broader. So ciprofloxacin we would use for gram-negative infections, pretty much urinary infections. Levofloxacin can be used against gram-positive microbes, strep for example. That's why it's a pretty good coverage for community-acquired pneumonia. The general consensus is you do not use quinolones unless patient is penicillin allergic or has a pseudomonal infection. And there is of course a reason for that. I'm not just biased against fluoroquinolones. FDA has issued black box warning against fluoroquinolones in 2008. Ciprofloxacin, levofloxacin, they have been implicated in tendinitis and tendon rupture, also peripheral neuropathy that's irreversible, and central nervous system effects. These severe adverse reactions were usually observed in older patients over 60 years of age, those that were taking corticosteroids, patients with kidney, heart, and lung transplants. What has also been reported is convulsions, hallucinations, mental health side effects, prolonged QT with fluoroquinolones, and increased risk for Clostridium difficile infection. There have been several fluoroquinolones that were withdrawn from US market, and here's the table listing them all. The only reason one would withdraw any antibiotic from the market is because they were independently killing patients instead of actually helping them. You might not be interested in the actual mechanism of injury. The mechanism is actually not exactly known. There have been few mechanisms postulated, like ischemic vascular process, direct toxicity to collagen, or possibly even oxidative stress. It has been argued that especially in renal transplant patients or in patients with acute renal injury, you will have accumulation of these toxic byproducts. And that's how this tendon rupture or tendon injury can occur. Let's talk briefly about sulfonamides. That's our Bactrim, trimethoprim, sulfamethoxazole. Sulfonamides inhibit bacterial folic acid synthesis. They are bacteriostatic. We have been using Bactrim for treatment of several unusual organisms like nocardia, pneumocystis, even toxoplasmosis. Bactrim is very frequently used for treatment of skin, soft tissue infections, abscesses. It has a good coverage for Staphylococcus aureus, whether the methicillin sensitive or methicillin resistant Staphylococcus aureus. Very important point, Bactrim sulfonamides elevate serum creatinine based on the mechanism in proximal convoluted tubules. And so it can lead to a rise in creatinine, and especially in elderly, it can also cause hyperkalemia. When we talk about antibiotics, we really have to talk about resistance. Resistance is coming with every single antibiotic developed. Every year, CDC releases their threat report, and this is actually a report from 2019. On the urgent threat list, there's the carbapenem-resistant Acinetobacter, carbapenem-resistant Enterobacteriaceae. Also, drug-resistant Neisseria gonorrhea has been climbing the list. Most recently, you have been hearing about Candida auris, which has made the news, and we continue struggling with Clostridium difficile. But as you see, we have pretty much an example of every single type of resistance on the list of serious threats, concerning threats. We have Campylobacter here, we have VRE, we have Pseudomonas, Salmonella, Shigella, even MRSA made it on the serious threat list. Strep pneumoniae is increasingly more resistant. A very global threat is drug-resistant tuberculosis. Tuberculosis in general continues being the most common infection that is a cause of mortality worldwide. So because of that, this slide is going to be the most important slide for you. The first and foremost, you have to decide whether or not the patient has typical signs and symptoms of a bacterial infection. If not, don't even think about it. Do not start antibiotics. You can always start antibiotics if patient worsens clinically or something else points you towards the diagnosis of bacterial infection. If you're sure that bacterial infection is the highest on the differential or pretty close to the top of your differential, sure, obtain cultures, start antibiotics, and at 3 days, review those cultures and decide yet again, do you have an actual infection or is it colonization? Every single day, you should be reviewing sensitivities and streamlining those antibiotics. I hope that you will help with the threat of progressive resistance in bacterial species and that you will obey the 3-day rule by continuing broad spectrum antibiotics beyond 3 days, drastically alters microbiome, and it specifically selects for resistant organisms. I hope this was an educational lecture. This lecture is available with a link on my private YouTube channel. Let me know your questions, your comments, and have a wonderful antibiotic conscientious day. Thank you very much. Bye.